So, good morning, everyone. Well, good afternoon now. Today, we're going to have an exciting presentation on medical gaslighting. It's part of the cycle of webinars of bioethics funded by California State University's Bay. And we have the pleasure of hosting the lecture of Dr. Bondurant. I don't know why I'm pronouncing it with a kind of a French pronunciation, who knows?
It's French, so.
Wonderful, so I'm right there. Okay, yeah. So the floor is all yours. We will dedicate 40-30 minutes to the actual presentation, and then we'll have time to questions and answers. Thank you for being here.
Great, thank you so much for having me. I will go ahead and share my PowerPoint here. All right, so my name is H. Bondurant. I am a visiting assistant professor in philosophy, but also PPEL here at University of Richmond. So basically that means the PPEL stands for philosophy, politics, economics, and law. So I take a very interdisciplinary approach. Sorry, this is my second talk actually of the day, to my work in philosophy, and the goals that it will be something that not only philosophers can use, but people in all sorts of professions, not just in academia, but actually out into the world and apply it to things like public policy, but also your own personal lives. So with that, I'm here today to talk to you about medical gaslighting, self-knowledge, and epistemic injustice. So one of the big focuses right now is data that we've already known for years, but is finally getting mainstream attention. So Black women and people who are pregnant in the US experience some of the highest infant and maternal mortality rates in the world, even when controlling for factors such as socioeconomic status. So this is a very interdisciplinary kind of talk, but this is why it's also important to do intersectionality as we do that, so that we can see ways that it does impact particular groups of people, but also we can notice how prevalent it is even when we take out other intersections like socioeconomic status. For instance, Serena Williams, right? One of the, if you don't know who she is, I'd be shocked, but one of the top celebrity athletes in general in the world. And even for that, she has come out and spoken about her own experience of a near-death life experience when she was pregnant, getting ready to go into labor. So we'll come back to that. Her experience, though, one of the things that stands out is that she was ignored, but because maybe she's Serena Williams, was able to keep persevering in the face of that feedback she was getting about herself. The recent Hulu documentary has come out that is called Aftershock, is also about this epidemic. And then Yolanda Wilson, who is a philosopher, is also a leading bioethicist working on these kinds of issues, particularly for this community, and more recently in focusing on issues in COVID. But for my purposes today, I will be using this group in the case of actually Serena Williams later to apply these ideas. But I'm also going to show you data of lots of different groups and cases that medical gaslighting also seems to be a phenomenon that appears. So philosophically, ethically, medically, we should care about what exactly is happening in these cases, the causes, and the implications for other forms of dangerous discrimination that might occur in these medical contexts. So for the plan for today is going to give you a working definition of medical gaslighting, present what I think is a real problem for self-knowledge and first-person authority, which includes its role in autonomy and decision-making and informed consent. And from there, I'm going to present this concept that I call disformative feedback. So it's a kind of feedback that changes your relationship to who you are, or can actually change who you are as a person. And how medical gaslighting seems to be a particular kind of disformative feedback. I will then show how medical gaslighting and disformative feedback under my account can be considered for a kind of epistemic injustice, which is a special kind of harm that can be done towards a person in terms of their rights and abilities as a knower. So we'll get more into what those concepts mean. For now, focusing again, just kind of on that term medical gaslighting. So medical gaslighting is drawn from the Black activist Shasa Adi. So you see her picture there. She was starting a nonprofit organization for those with polycystic ovary syndrome, which affects about 6 to 12% of people with ovaries in the US. However, it's rarely diagnosed. Accurate diagnoses usually take sufferers decades before they can actually get diagnoses, which includes then, of course, multiple expensive, dismissive doctor's visits, having to navigate through the system, different hospitals, different doctors across time. And these tend to lead people to report experiencing depression, anxiety, based on the fact that they're not only getting their physical pain untreated, but they're then facing these other kinds of barriers as they are seeking treatment. So when medical authorities dismiss one's pain or assert that one is mentally unstable, as sometimes people tend to believe about some of the women coming in with this kind of pain, since there's rarely physical markers for it. When people get this kind of feedback that it's in their heads, they begin to then, of course, doubt themselves. This doubt unfairly interferes with one being able to appropriately and rightly reflect on one's own physical and mental states. So this interference with one's self-knowledge, one's ability to know oneself, is what I'm going to claim is a particular kind of epistemic injustice, and that one that is actively perpetuated through different kinds of medical feedback. And I think, did we skip past the gaslighting slide? All right, well, maybe we'll get back to it. So, we'll get back to it in just a second. All right, skipping ahead a little bit. So the medical feedback, you might say, okay, well, what does Dr. H mean by medical feedback? Well, the idea there is that there is all kinds of sources that we get information about ourselves from. So I might get information about myself from another person, a conversation. I can also get it from an institution and the kind of policies that I consider myself to be affected by in some way, the norms, the rules regarding where I belong, what I should be doing. And these, of course, can be explicit. So, of course, with medical feedback, we have things like diagnoses, but also things like availability of resources, the kind of care and attention one receives, the autonomy one has in deciding what kind of treatment plans one wants to pursue. All of this gives a person a certain kind of information about oneself, one's value, one's worth. And these medical systems do have widespread power in terms of deciding who is considered, say, an expert, who is given authority for these kinds of medical decisions or feedback. Given this kind of authority, the decision-making power, the power over access to resources, the feedback is also going to obviously greatly influence the person, what they know, and how they can behave, what they're able to actually do, even regarding their own physical and mental states. So given how crucial still medical expertise is for our well-being, I'm not rejecting that we need it, it still just shows how the impact of medical gaslighting is severe enough that it must be taken seriously. So now we get to the gaslighting, right? So gaslighting is become increasingly popular in both academic and public conversations. Gaslighting is, if successful, results in distorted memories, self-doubt of one's perceptions, memories, experiences, and abilities as a knower. One's ability to track what is actually happening in reality. So despite this being a very common term now, it still remains very under-theorized in medical cases, which is why I chose to focus on it specifically as a concept here, especially since some activists like Audie are starting to begin to use that term to explain what they feel like is happening in their own cases, not just as individuals, but as groups who are facing particular kinds of diseases. So the concepts we have currently, gaslighting was 2018's word of the year, and they differ a lot on, say, intentionality, how much manipulation and malice need to be involved as a necessary condition for it to count as gaslighting. But in general, across the board, they all tend to converge on the goal or the purpose behind the gaslighting to be that it causes the person or group to question their reactions, their perceptions, their disagreements with what the information they're receiving, the memories, their own beliefs, in such a way that, again, it causes them then to doubt their reality, doubt their access and evaluation of reality, because of that doubt being planted. And as I'm going to say, causing a kind of interference or severance between the normal relationship one would have to one's own states. So again, my focus on medical gaslighting is to look at the kind of harm it does or attempts to do to one's ability to know oneself, particularly one's bodily and psychological states, as well as one's own experiences. So when medical gaslighting is internalized, one is no longer able to use one's own experiences, one's reflections as the basis for forming beliefs about themselves. One is no longer able to relate to oneself in the same way, since now the medical authority has dismissed this necessary personal first-person authority required for self-knowledge. And since we see this dismissal happening more often towards marginalized groups, such as Black women, it should raise a red flag that this is most likely related to some kind of identity prejudice, and in a way that could be contributing or perpetuating oppression by distorting certain group members' abilities to know themselves, and therefore act in accordance with their own agency. So authority and self-knowledge, I've already mentioned some things about autonomy, which I'll come back to, but first-person authority is one of the most important roles of self-knowledge to us that then we use as justification for again, may not be the only reasons that we have autonomy that we give to people, but it's one of the major ones, right? Which is why we have things like informed consent, why we wait to let children have informed consent, because they're still learning how to develop their sense of self, their rational agency. But this first person authority, it's how we communicate, it's how we trust each other, it's how we assign responsibility, it's how people are able to hold you to your word. So epistemically, the idea is that you're considered to be in a certain kind of privileged position because you can access your inner states, your bodily states, your experiences in a way that no one else can do besides you, right? And again, maybe you're not sure how accurate you are, and that's okay, because even if we aren't always accurate, depending on how you look at introspection, there might still, again, be a moral reason for us to think about the first personal authority as necessary to grant not only for self-knowledge, because it allows us to then think about the moral right that one has in being able to express certain kinds of states and being believed. This authority can also be considered not just in the first two, but also in terms of social. This is what we're going to see a little bit of today, and how that is also taken away, in the sense that first person authority, in terms of its social power and how others respond to your first person authority, how others trust it, how others grant it some kind of credibility, all of those things also have to do with the way that there's a social element to first person authority, not just this kind of individual element. And of course, going back to autonomy, as you can see, all of these are going to play into how you are able to weigh your reasons and make your choices, how you're able to understand what abilities you have. And that plays also, of course, into what kinds of intentions you're going to set, what kind of goals do you think you're going to be able to go for, given what might the effective means even be, right? If there are things that are not open to you as options at all, what does that do in terms of your decision-making power? Well, it can take it away, but that's a very different situation than if it's taken away without you realizing that it was done from the outside and it was something that you didn't choose for yourself. So I'll show a little bit of how that works here with this little diagram. So basically the idea here is when we're thinking about how we get feedback from others, which of course we should get feedback from other people, whether it's related to medical feedback, whether it's I have a blind spot about how I come across when I'm hangry and someone else needs to point it out to me, right? All of those things are important and necessary for having an accurate picture of the self. So it's not always your first person authority that you're relying on. But as we do things out in the world, we notice our personality traits, we behave in different ways, we have experiences with our bodies, we interact with others, we do get this kind of feedback. And the typical story is, whether this is always how it works, as I'm going to show, but often the way it's talked about when people are thinking about feedback is that, okay, I get the feedback, and then I later self-reflect on that feedback, right? And it may be in the moment you're reflecting on it as well, but maybe later, you think about, oh, well, what were they saying about what I do, right? Like what ways do I act? So you might reflect through memory, or maybe, again, going back to the hangry example, when you realize that you were sounding a little sharp in that moment, right? That feedback that you got from before might change your own interpretation or reflection of your actions in that moment, because you had that feedback about how you might sound sometimes when you're hangry. So the idea there is, once you can have this kind of self-reflection of the feedback and the traits, you can go ahead and then think about whether you want to accept that feedback or if you want to reject that feedback. And if you accept the feedback, usually, if we're rational, ideally we would maybe update our belief system. And if we, depending if we like the feedback, maybe we don't like the feedback, but we may change our beliefs and behaviors as well based on that feedback that we've come to accept. So this is, again, not just for medical cases, but kind of just a very bare bones kind of explanation of how this process of self-knowledge is thought to work. So there are some really important belief practices that we want to make sure we hold on to in self-knowledge, especially if we care about it for things related to autonomy and decision-making. So first is being able to use one's own introspective capacities, that self-reflection, in a way that is it's to the best of one's ability. So it's not been interfered with, it's not been distorted in some way, it's not been coerced or manipulated. You want to also be able to recall accurate and not false memories. And then you also want to have the kind of concepts we need to be able to track reality. So these kinds of concepts include being able to understand what's happening inside of ourselves in order to recognize and understand and communicate our bodily and psychological states and experiences. So in general, I will be focusing often on pain, mental states, and bodily experiences, just as a kind of way to kind of group them, but I don't necessarily claim that it's only one thing is happening here. They're usually all happening at the same time. So starting out with, I'm going to go briefly through some of these cases since they're more just kind of showing you how comprehensive this is. So again, this is another picture of Shasha Adi. So women's pain, regardless of race, there's a large amount of evidence that shows their pain is often dismissed as being emotionally based and not real. We can see this in the amount of prescription medicine they receive for their pain, as well as wait times and diagnoses in general. They are also then likely, given that there's the impression that these things are emotionally based, they are rarely going to actually have their pain seen as the cause of any emotional distress. In fact, that is going to be maybe seen as the reason that they're in pain, is there's something going on in their heads, and that this is something that's not actually based in anything that they could treat. They just maybe need to go get therapy or something like that, right? And actually, some of these people are committed by doctors when they seem to not be accepting their psychiatric condition. So even if it is psychological, even when the women want to acknowledge that, it is still often dismissed as not severe enough that it should be taken seriously by the medical community, right? So that comes from a paper that's a really comprehensive review of, which I'd be happy to share resources. But this is also one I really want to focus on, I think is a little less well-known, which is a book by Seth Holmes. So it's on the pain of, well, he's an anthropologist, but he's also a physician. And so he catalogs narratives and conditions of migrant fruit farm workers, predominantly Mexican. And so he documents how they suffer from more than just their working and living conditions alone, that the racial stereotypes and oppressive structural factors around their working conditions, such as a lack of stable funding at the nonprofit clinics that do serve them, prevent them from proper health care. So then the workers are then often perceived by their employers, healthcare professionals, and sometimes even the migrant workers themselves, perceive themselves to have natural differences that make them more fit for the grueling work of being a fruit farmer. So the Triqui Pride, the Triqui people, a large group of people that end up working at the fruit farms, they tend to pride themselves on their strength, their endurance, and being unaffected by the strain of their labor, and the literal backbreaking work they do. So the thing with that is the medical reports, the medical feedback they're getting, sometimes, often actually, provides explicit information that suggests that the healthcare professionals also tend to hold these patients in that light. And also, because they hold them in that light as being physically different in such a way that then they also seem to hold them blameworthy for whether it's the natural differences, such as some doctors put the bone structure is harder to work with, that their bodies are lower to the ground as excuses for why they were having trouble treating them. But it's also can be things like cultural differences, and the reports will say things like the workers are, they have a poor diet, or they're dirty, or they're lazy, which obviously seems very counterproductive to everything that else comes up about that. And also going so far, even sometimes to put things like moral judgments, making unwarranted claims regarding potential domestic violence as causes without any other evidence to support that from the family or from medical reports. And so all of this medical treatment and these kinds of reports then become a form of feedback that are going to impact how these migrant workers are not only able to see themselves, but also how they're actually able to move through their world, through their community. And that one of my arguments here is that this kind of medical feedback is giving them the kind of information that they belong in these kinds of ordained social locations, right? Where they're not receiving care like others. And so another example would be something like the lack of Spanish-speaking services. That's a structural factor that actually makes it just impossible sometimes to communicate at all. So then the belief by some of the migrant workers that this healthcare is not going to help me is not actually a false belief. It actually does seem to be supported by the evidence, given the ways that the healthcare systems are set up for them. So historically, we can also look at cases in which there are mental states that people have been able to identify, but are categorized in different ways according to the medical system. So hysteria is very well known. I'm going to go and talk about homosexuality on this next slide. But in general, even though those are historical cases, we still see often mixed diagnoses of mental instability across lots of different cases instead of giving the proper treatment, which then leads to depression and anxiety, which seems to provide evidence for that previous misdiagnosis of mental instability. So for example, with homosexuality, with conversion therapy, so again, I'm kind of assuming some people are familiar, but homosexuality was considered a disease, a psychiatric disease, and that gives a certain kind of informational content as well as normative content regarding what you may come to believe or see about how you see yourself if you're experiencing these kinds of mental states of, say, sexual attraction to someone of the same gender. And so conversion therapy was actually the doctor who started it. He actually had good intentions, For him, it was a way to have something that wasn't electroshock therapy as an option for treatment, because that was the most common one at the time, was electroshock therapy. And so conversion therapy has had more to do with some different kinds of conditioning, but not necessarily pain. Still very harmful, but the idea there for the doctor was that he had so many homosexual patients coming in asking to be cured, asking for help because they had been told they had a disease. So of course, this the person who started conversion therapy, he actually started working against it. And once he was able to come across different social activist groups, that made him realize that it was not something wrong with the person, but it was something wrong with the society that he was a part of. So again, this is not something that's actually really far in the past either. So things like continuing to exclude homosexual men from donating blood if they're sexually active is still a current kind of medical feedback that they are likely diseased and dangerous. And so any sexual activity with another man, even if that man is one's partner, excludes one as being a person who can give blood. And that again gives you a kind of information about your value, your worth in the medical system and also in society at large. So I'm gonna go briefly through this, but one of the other things to think about is bodily experiences. So the supposed obesity epidemic, just many people would claim, distorts the way that people relate to their bodies. So medical systems dispel the feedback that one's body must be a certain weight, have a certain physical abilities in order to be healthy. And so when these categorizations happen, they actually affect every person's experience of their bodies, not just people who are obese. And so when I'm using the word fat here, I'm using it as descriptive, value neutral, and actually separate from the medical terminology, since that's a word that many actually reclaim and feel comfortable using for themselves. But the BMI, body mass index, still carries this kind of authoritative weight, no pun intended, within the medical systems, including public health and clinical research. Access to resources is a huge one. But since it's merely a height weight ratio, the BMI is a very unreliable measure of such factors, such as ratio of fat tissue to muscle or risk of heart disease. But it's still one of the most used indicators. Many argue that it leads to actually several diagnosis problems and can mislead people to reduce their fatty tissue in ways that could actually worsen sometimes whatever condition they're coming in for. And we see this actually with polycystic ovary syndrome, because a lot of people who have it, one of the symptoms is actually gaining weight. And so many times people come in to receive treatment and they're told that they need to, exercise more and change their diet, and then they'll start feeling better. Which of course, given that the PCOS is actually causing this to happen, none of that is going to make any difference regarding the person. And so I don't have time to go into the false memory diet, but that is there are lots of ways that we can now see research of false memories implanted in ways that actually impact things like what kind of food people are going to eat. And so the idea that a false memory, one of the scary things about a false memory is it's indistinguishable from something that might be actually an experience that you've had in the past. So you might think that you had a really negative experience with this food. You start to avoid that food, but you don't realize that that negative experience never happened. It was just implanted in a certain way to impact your future behavior. So what I call disformative feedback is this certain kind of feedback that transmits this kind of false, erroneous, unjustified information. Feedback itself can be transformative. It can change you. When one is developing either as a child or a new career, feedback about the self, it shapes who you become. Feedback tells you where you fit, but even if it's inaccurate, you're often going to attempt to conform to that feedback, or it's going to make you conform. So to some degree, you must, in order to move through the world successfully and make sense of your identity, conform a bit to the feedback. However, having this false or distortive evaluation of a person, that can attempt to control or transform the person in a way that then confirms that false feedback. So there's two elements here. There's the transformative element, which is the formative, but then the disruptive element, and that it is going to sever the appropriate process of self-knowing, of how you should come to know yourself. So this normal practice is distorted because now a person distrusts their first person authority regarding their mental and physical states. They're not sure they should trust their interpretation of the circumstances. They lack autonomy in discovering and deciding what their own mental and physical well-being is. And so the person's, to give an example of how then this kind of goes back to confirm the feedback, is, say someone is always going to see different doctors and not being treated for their pain, it is going to look like, it can easily begin to look like they're someone who complains, because they're going to see doctors constantly, they're getting dismissed. And as they are getting dismissed and being told they're being a complainer, they're also being told to doubt themselves, encouraged to self-doubt. And so they're going, again, the medical systems can then create a seemingly accurate representation of the feedback. Through the feedback and the treatment from the medical system, it can seem that the person is now fitting whatever in originally inaccurate representation of the patient to begin with. So just to give a quick example of how Serena is a case of unsuccessful medical gaslighting. So she was experiencing an unfamiliar pain during labor. She asked for a specific treatment based on her own medical history with blood clots. She knew what was happening in her body. However, the nurse reacted as if Williams was just confused from the medication. She said, "Oh, you're just out of it. Don't worry, the doctors know what they're doing." She continued to persist in communicating what she believed to be wrong, the treatment that she knew she needed. When a doctor finally intervened, it was not the test or the treatment that Williams had recommended. She continued to resist the medical gaslighting, the dismissal of her first person authority, by persisting in her own understanding, her beliefs, her experience, her perception of pain, her mental stability, and the real threat to her body. The doctor finally did as she said, but only after he had tried every other thing. He ended, and again, it helped, most likely helped that Serena knew exactly what kind of treatment needed to be performed, which of course, many of us may not actually have that information. So someone who's even known for being famously known for their physical abilities and knowing their body as an athlete still got feedback that she lacked first person authority and self-knowledge. Right. So here is just another kind of diagram of how that works. So instead of the reflection being on the feedback actually impacts the traits, the behavior, the way you're experiencing your body. The medical gaslighting is also going to impact your self-reflection. And so as you're doing this, again, the interference is that you can't actually understand where this feedback is influencing your ability to make decisions, ability to know yourself, because we can't always separate it out. Again, some of it's explicit, but some of it's implicit. And even if I choose to reject the feedback, that might not actually be an option, because something like a misdiagnosis is not something I have the power or authority to even reject. If you're not going to give me access to a certain kind of treatment, given the structural power, I have to accept that. I have to accept that institutional fact that you have given me a diagnosis or lack thereof. So I know I'm running a little bit over time. I know we started a couple minutes late, so thanks. So there's two kinds of harm I want to point out. They obviously work together, but they're going to be important for our purposes in understanding epistemic injustice. So there's two kinds of harms here. The epistemic harm is the idea of disrupting this process of self-knowing. We care about it morally, of course, as well, because we want to be able to say that someone has self-determination, someone has autonomy, and being able to know when I have accepted this feedback and I'm reacting to it. Again, that is something we think should be a choice. And given that a lot of this feedback is based on social status or one's social position, it makes it even harder to know whether to trust this feedback, whether it's actually credible or not. So epistemic injustice is an unwanted or unfair harm towards an individual in their capacity as a knower, such as sharing or gaining knowledge. Again, for our purposes, we're looking at gaining knowledge in the sense of being able to form beliefs about oneself. So when medical gaslighting is systemic, when it takes place across multiple kinds of structural and gentle sources, it's systematic in a way that, again, it's not based on one individual, it's based on the group membership, right? And this group membership is usually because of some kind of identity prejudice that is preventing a person from being able to exercise their rights and their autonomy in a way that often is trying to keep them in oppressive conditions. Finally, as I've been noting, that first person authority is key to being severed in some way that we consider to be unjust. So this is just a general breakdown. I can go ahead and even put this back up when we're doing the Q&A, but this is just the analytic kind of breakdown of my arguments. Basically, yeah, I'll actually come back to that because I think I pretty much said everything that's on there, but I want to just throw up some objections to my stance so I can get some feedback from y'all on this. So some objections that I've been coming across. First is this idea that the medical sources is an important, different third-person perspective. And the goal of medicine is obviously not to distort, but to provide really important information. So it's different from a first-person experience, right? So my stomach hurts is very different from there's a tumor in this person's stomach, right? Those are very different perspectives, propositions, but while expert medical sources, my reply is while medical sources can provide important justification from their perspectives, there's a lot of evidence that show that medical sources often go beyond just that perspective, go beyond just this, just the neutral facts, and usually there's a lot of normative force in the ways that these diagnoses are presented or conceptualized, or the way I want to say gatekeeping, but in terms of who is able to actually always even get the third person perspective on in a way that they're seen as not just objects, right? So second, all three of these I think relate to each other in some way. This is me kind of picking out objections from different feedback I've gotten, which is that many do think that, by my account, it makes medical gaslighting would not be very common because they want to say that, oh, well, it's unintentional, that most doctors don't actually mean to do this, that the medical community isn't setting out to gaslight people. And in the cases that there are people who are doing that maliciously, it's very rare, very unlikely. And given the self-reports from people like that social activists who are, whether it's the PCOS group, whether it is the disability community, whether it is the fat community, these are groups that are saying this is not rare, this is not uncommon, and that there are many cases of gaslighting that would say it doesn't have to be intentionally malicious to still count as gaslighting if it meets these kinds of conditions. Finally, I do want to be able to have a place for medical expertise in my account. But one of the overall questions of this project, of my work in general, is when do we give more weight to another person's perspective of us, other people's beliefs about us, over the beliefs we have about ourselves? Sometimes we should, given we all have blind spots, given I'm not a medical doctor, I need that expertise. But there are times where we do need to recognize and reject other people's perceptions of us, especially as the queer community has, and still, especially the trans community is continuing having to do. So I will stop there since I went over time. I appreciate so much for letting me go a little bit deeper in detail than I sometimes get to do at conferences. So I really appreciate the chance to share.
Thank you so much for this great presentation. I mean, there's lots to say. Please don't be shy. Ask your question. The floor is yours. Unfortunately, we have 10 minutes. Go ahead, William.
All right. If we start from the perspective that medical gaslighting is occurring but not intentional, what's causing it?
Yeah, so that's a great question. So a lot of people working on, say, feminist philosophy, law, philosophy of science, are looking at ways in which social positions, culture, the social power, people in power often want to create certain kinds of categories or structures in order to control people or make things more efficient, let's say. So for instance, I'm sure some people in the eugenics movement probably would have thought themselves to have very good intentions, but the fact that they thought they took themselves to have good intentions doesn't mean that they weren't contributing to creating a structure that was going to be oppressing certain groups of people. And so I take a lot of that kind of research from others in my own work, because it's actually quite broad. There's lots of different things you could look at regarding it within the medical community, but also just in terms of the fact that, for instance, a lot of our research has been done on a certain kind of body, right? And that's why there was a lot of ignorance regarding women's health for a long time, because that was not the body that was used as the default norm. So it's those kinds of things where if you don't it's not that I'm trying to hold necessarily individuals responsible in all of these cases. It's that it may not even be the individual's fault if that's all they have to work with.
Katie, thank you so much.
So I had a question of kind of what do we do about this? The entire reason I went back to school, honestly, is medical gaslighting. So I had stage 4 endometriosis and had 4 surgeries in 14 months. And I see so many people, little bit of statistics, endometriosis affects 1 in 10 women between the ages of 15 and 49. That's 200 million women worldwide. The endometriosis march started in March of 2014, and we've been doing it annually and growing every year. But one of the biggest issues is that it's systemic, because we can't get ACOG, the American College of Gynecology, to acknowledge endometriosis and focus on it as a specialty. So kind of where do you go with this?
Yeah, I wish I had a more hopeful talk in that sense. I think, the thing that I guess I'm most hopeful of is the more we talk about this, the more accountability is hopefully going to start popping up. And eventually, even if it's unfortunately, like I said, I don't want to hold just individuals responsible, but that pressure might be what makes its way up to policymakers, to institutions having to rethink how are we doing these things. And I am really also optimistic by things like health humanities and narrative medicine and things that are starting that are very patient-centered and having events. So I got my PhD at Duke University, and sorry, don't hate me if you're a UNC fan, but I know I am wearing light blue. So, but one of the things I was really impressed by at the Duke University Hospital is, and I got to be a part of these, is they would have often open to the public discussion roundtables where doctors would come, patients would come, students would come. Me as a philosophy grad student could come, and sometimes it would be a doctor sharing a story of why they decided to go into narrative medicine and why they're fighting to make sure that they have longer times with patients now. Right. And so things like that make me optimistic and hopeful. And unfortunately, even if we want to change structural injustice, it still actually is going to be individuals doing the work.
Hopefully I can make a difference, because that's what I want to do.
Please feel free, of course, to also email me. I don't know if my email has been shared, but I would love to keep in touch with anyone who'd want to keep in touch about this stuff.
Yes, definitely. It's a huge topic, and I have found social media has been a huge support and a great way to be educated on things that doctors aren't even aware of. So.
Yeah, it's interesting. I actually people are really worried about misinformation, which I am too. And I'm also very worried about my argument being, I started working on this actually before COVID, and I took a little break because I was a little worried about like how my argument was going to get construed about being like anti-doctor, anti-medical expertise. So I actually like took a step back for a little bit, like, because I was just like, I don't want this to be taken out of context and how I'm using it, right? Because I do think like, I definitely am trying to listen to doctors, but it is really important that things like, I agree, social media, like misinformation is a huge problem, but I am not anti-social media, because without social media, I don't think some of these groups would come together. I don't think the kind of accountability would maybe be as, wouldn't be as forceful. So I'm right there with you.
Awesome. Thank you.
Anyone else?
I have a question.
Yeah.
In your section where you talked about false memory diet, I was kind of confused on what false memory diet means, and if you could just re-explain that, that would be great.
Yeah, no, I always try and I did to edit more and take out the bullet points that I'm not going to be able to get through. So I apologize. I just got excited about how much time I had with y'all. So the false memory stuff, I don't know if people are familiar with false memory research in general by Elizabeth Loftus. Loftus. And so she's most famous for now bringing into question eyewitness testimony. And her work is actually super important. It shows how susceptible we are to false memory. And that case that I came across when I actually have just a short paper just about how easily someone can suddenly wake up, go to sleep not fat, and then the next morning their body be exactly the same and suddenly they're fat according to like the BMI. And so with the false memory diet, there's two elements to it. First of all, just the false memory research folks who like don't actually care about the moral stuff that might actually fall out of doing this research with people. And then the reason I came across it was also because people are like, oh, look at this false memory stuff. This could be we could use this, we could harness this for weight loss, okay? So I just wanna say like the false memory folks are not, like I'm not blaming them for what happened, but it is, when you're doing research, it's important to think about how it can be used, right? So the false memory diet is basically it can't be like really extreme. It can't be like like a food you eat all the time. Like if you ate ice cream like every other day, it wouldn't be able to keep you from eating ice cream suddenly. Okay. But let's say there's a food that you do enjoy, and over time they would have these sessions with you, and they'd give you like little stories about, like, you know, they give you little stories about yourself and your past. And I'm totally paraphrasing here, so I can send out the actual paper as well, but I think if you type in Loftus and false memory diet, this will actually come up, the original. But basically they were able to manipulate people into believing that they had an experience with this food that was really negative. So maybe they got sick off of it. I think it usually was they got sick in some way, or they just really were manipulated into thinking they disliked it, right? And so then to test that was a false memory was, first of all, them not being able to report on it being something that was false, right? Like them being able to report on it as if it was something that actually happened to them in the past. And then also when given options of food, they will then, this is the part that really freaked me out, is they will actually start to not go for the food that they were told they had a negative experience with. And so now, again, it's not like, this is not like a new fad that's already on the market or something, but this is work that's already starting to happen in ways that people are thinking, oh, well, if I want to lose weight, maybe I just need to trick myself into thinking I got food poisoning off potato chips and now I'm going to be okay, right? So that in general is just one example of how actually I don't think it's happening in that way all the time, obviously, but I think that happens in other smaller ways, more subtle ways that we're given feedback about our eating habits, whether we're fat or not, right? And so if you're told a certain thing about how you should eat, your experience of eating that thing is going to be affected by that, right? So that is actually why there can be a really large, there can actually be a lot of eating disorders and people who are overweight because they start to, they should be eating, but because they're given information that what they're given, the kind of feedback that they're eating is wrong in some way, that can lead to a higher occurrence of eating disorders.
Got it. Thank you so much.
We have time for one more question. Don't be shy. I know you have questions in your pocket. Okay, I have just one comment. You know, I don't think that the objection about intentionality can be sustained. I mean, it really seems that they intentionally have to make the visit that short because they are overworking, because they have a long line, because they have a protocol. And you can really see that they are set on the intention of, I have to contain this dialogue in these bullet points.
Mm.
Yeah, I think that the objection on intentionality is not that strong.
Yeah, and it's so interesting that you shared that, because another way I've heard that objection phrased, and it wasn't actually, it was just kind of going back to the original question of like, well, how do we fix this? Is thinking about just the short times and how, and you know, I do have friends who are medical doctors, and
exactly. I mean, they have to survive.
Yeah, no, it's extremely difficult, and then they get really frustrated. I think almost every medical professional I know is frustrated by the lack of time and they get with the patient, and especially the time actually they spend doing things like busy paperwork, where they don't even feel like, they just are trying to check off as many boxes and give a clear, give a clear yes or no kind of answer, even though they don't feel comfortable with it. And so I think that is like, we can interpret that as, yes, they have the intention to have to get it done. But in another way, I also interpret it as they feel a lack of autonomy in those situations, right? Because they're not getting to perform medicine the way that they actually want to perform medicine, the way they want to care for people.
Hence, the system is somewhere intentionally stupid. I mean, sorry.
Well, I mean, it's interesting, especially because I always think about being in the US and this like really being a really big problem for the US, because especially thinking about the cost of navigating healthcare. But I just went to another conference this week, but I was at another conference where they were talking about medical diagnoses as being an institutional fact, where it's the way the bureaucracy works, regardless of whether you have your universal health care or not. You're still, the way we've set up the system is, at least in Western medicine, there's a lot of holes. And I think it does go back to actually the purpose behind medicine. A lot of it is related to when we started criminalizing behavior. So those criminalizing behavior and pathologizing behavior, things actually grew up together.
Yeah, the way we use technology, because many things are delegated to technology, and technology doesn't ask sometimes the right emotional questions that need to be asked. I don't know. Yeah, it's a big topic, but I think that intentionality has a huge place. They might not have space to be intentionally who they want to be. That's true. Yeah. Anyway, yeah, it leaves me every time so sad to talk about medical gaslighting, because we are so far from solution and it's creating so many problems still. Yeah.
Well, this is encouraging me that maybe I should make sure I have at least one slide up with some possible thoughts or optimistic routes to maybe go explore.
Yeah, who knows? Yeah. And I think that in the US the situation is different than other countries. I mean, I live in between Italy, where medical expenses are for free and so on. And in the US, there's the rigid healthcare system with health insurances that get in the way. Anyway, yeah. I'm sorry I took the space for your last question, but if you have more questions you want to ask, I paste the email of Dr. H in the chat. I think it's a very fascinating topic, both for my class of philosophy of feminism and bioethics class. So if you want to write about this topic, I will be absolutely happy to read it in both classes.
Yeah.
Yeah, and thank you all to be here, and for thanks for your great presentation and for the questions you asked.
Thanks so much for being here, y'all. And I'm happy to stick around for a couple minutes too, if people want to chat.
Thank you. Have a good one.
Thank you so much.
Have a good day.
Thanks.
Bye, everybody.
Bye.
Thank you.